The Systematic Approach to Improve Care for Frail Older Persons, SAFE study, was funded by the Health Research Board and involved a partnership between University College Dublin, St Vincent's University Hospital, public and patient partners, and community and rehabilitation sites. SAFE was created to help implement a new model of excellence in the delivery of care for frail older people through co-design and collaboration. Hospitalisation can lead to decline in frail patients. Hazards such as falls or infections may occur, and prolonged bed rest in itself can take a toll on the body. In addition, changing wards can also increase the amount of time an individual remains in hospital. Our analysis of St Vincent's University Hospital Emergency Department data showed that adults aged 65 or older are disproportionately represented at over 33% of attendees, despite comprising less than 12% of the overall population. The number of adults aged 80 and over in Ireland is expected to more than triple over the next 30 years, and it is clear that the Irish healthcare system will have to adapt to meet the specific needs of a growing older population. To better understand the situation, we conducted a review of successful strategies in implementing a care pathway for frail older persons. Challenges included organisational boundaries, both in the acute setting and among community and rehabilitation partners. There was also a lack of opportunities for staff to build trust and understand each other's capacities. Suggestions were made to address this situation, including creation of opportunities for staff to build relationships and work in a more integrated way, as well as educational opportunities. Throughout, there was the sense that older people should be involved from the beginning of the process.
I suppose it's all about learning, and that is why we promote and we support research at all times within this organisation, because we want to have that culture of inquiry within St Vincent's University Hospital. And from that point of view, clearly we can see from this piece of research that we have made improvements for the patient's journey. From a hospital perspective and a CEO perspective, it is the fact of that you empower, you support your staff, and you empower your staff. And you empower them so that they exceed even beyond their own expectations. So I think for any type of quality improvement initiative or plan that you bring into an organisation, that it's really important that you have continuous monitoring. And to that end, you would bring things in like key performance indicators to ensure that the plan or the quality improvement that you have brought in is absolutely being a success and continuing to be a success. And the most important part is, what are the benefits to your patient? What are the benefits to your staff? And what is the benefit to the organisation?
To ensure that SAFE truly reflected and responded to the needs of patients and the community, older adults became vital participants in the co-design process. Co-design involves the creation of democratic partnerships to involve potential end users in the design of research, thereby promoting understanding, building capacity, and encouraging uptake of findings. 10 individuals from NGOs and community-based patient and public advocacy organisations worked with 8 healthcare practitioners and 3 researchers over 6 co-design workshops.
I had been involved in research to do with older people before, but never in a particularly hospital setting. And I also think it was a very interesting project. I particularly liked the mixture of research and practical application. I found it was very much hard because while I do have an involvement with Ajax, which is an advocacy group, I was primarily there as a stakeholder. So we brought our individual experience of being with people, frail elderly people who presented in hospital. I would encourage them very much, because everyone has had experience of maybe bringing someone to hospital, and sometimes it's a good experience and sometimes they feel it could be improved. And I'd also know myself of people who had very complicated and touch and go operations that went fine, and yet it's in the kind of simpler things that things can go wrong. You know, like bringing water and seeing that people eat, and all these things which seem on the surface quite simple, but they're not, because hospitals are complicated places. So I would very much encourage people to get involved in this.
The SAFE co-design group identified 5 key priority areas for enhanced service delivery. Collaboration along the integrated care continuum, improving mobility, access to food and hydration, continence care, and improved patient information and signage. In addition to an emergency department trial of the Frail Intervention Therapy team, we tested several interventions targeted towards creating improvements at patient, staff, and organisation level.
The main attraction was that it was a co-design process, and there was interaction and integration between patients, practitioners, and the public. Different public bodies were involved. It was a really interesting dynamic group to work with. It reiterated for me and reinstated for me the importance of communication at the core of all the work that we do. Not only communication between patients and practitioners and vice versa, but also amongst professionals and practitioners with each other. There was a lot of discussion around the table amongst the different groups that were involved in the project, and how those discussions have changed practice for me would be when I see patients now, I'm very mindful of what we discussed as intentional rounding, that we as a team are all mindful of the basic core needs of a patient, because often, unfortunately, it gets forgotten.
Intentional rounding is one example of our successful interventions. The staff carried out regular, structured checks on patients to make sure that their needs were being addressed. The intentional rounding approach considered the patient's 4 Ps: pain, position, possessions, and personal needs. We carried out intentional rounding in 3 wards and found improvements across all areas. More patients were not visibly in pain, more beds were at the correct level for the patient, personal possessions were more easily accessible, and a greater number of patients did not require toilet assistance.
I suppose the benefits of SAFE was hearing the patient's voice and making sure it was evident in our everyday practice, and making sure that we maximised all the staff's time and the patient's time and getting the most important elements of care across. And also from that, it was like linking the 3 pillars. So we had research, we had the patient's voice, and we had our clinical practice, and bringing them all together. I wouldn't say we had difficulties implementing SAFE, but I'd say there was some element of time. We needed to change culture, so it takes time and a lot of commitment. So you need to have everybody on board, both the patients and the staff. You need to be flexible with your approach, and you need a lot of ongoing communication. So the Plan Do Study Act was key to it, so you could start small and do the repetitions and changing one thing at a time to make it fit the culture of the ward. So the advice I would give to other organisations who want to implement SAFE is to lay a good foundation. So first of all, listen to what the patient wants and don't overcomplicate it to make it more sustainable. Keep it small and moving constantly.
We gratefully acknowledge all our partner organisations, communities and individuals who have contributed to making the SAFE programme a success.